कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतं शङ्करं प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. It gives me immense pleasure to welcome all of you today to this 18th episode of the O2S Obstetrics Masterclass web series. O2S denotes the O2S of obstetrics, covering most of the important topics of obstetrics that we have covered in this last 17 episodes. And we move ahead and we go ahead till April, where we'll do another 6 or 7 episodes where we'll covering the rest of the important topics for it. So in this series, the series convener is Dr. Jaideep Tang sir, and the co-convener is Dr. Parikshit Tang. And I'm Dr. Priyankur Roy, the moderator for today's session, and my co-moderators are Dr. Apurva, Dr. Niharika, and Dr. Rohan. So today we have an exciting session, or a talk on calcium and PIH by Dr. Chandravati ma'am, and an exciting panel on immunization in pregnancy by Dr. Preeti. And we have very excellent set of panelists with us. I'm very sure we'll have a very informative session today as well. So first of all, I would like to welcome the chief guest of today's program. It is none other than Dr. Naren Malhotra sir. So sir, we all know is a father figure, and he is there in all the organizations, I must say. I haven't seen an organization where he's not there and he's not holding an important post. So to introduce him, he has been a past president of FOXI, past president of ISAR, ISPAT, IFUMB, AOGS, CMU, where he's a dean. He's a vice president of SAFOG as well as WAPM, currently the president of INSARC, and we all know he's the director of the ART Rainbow IVF, which is situated in Agra. So it gives me immense pleasure, sir, to welcome you to this platform, and will request a few words of blessings from you, sir.
A very good evening to all of you. It's indeed my pleasure to be on this 18th episode of O2S. I've been watching all the 17 ones in and out, a little bit here and there, and I've been very excited about the presentations which have been made and what all has been talked. So today I've been asked to give a forward-looking statement. We are always looking forward. For me, looking forward means walking forward. And for me, walking forwards means that I have to take everyone up with me, walk forwards. And the person should be left behind. And that forward, and let's start walking forward together. So for me, forward, I would be 3 F's and 1 W. So first, forward, it is the most important thing which you should take along with you whenever you look forward. So, and care for them, because they are the only ones who are nearest. The second forward looking for me is friends. And here I remember a song from my childhood, Tom Jones singing, "I'm rich in love, a millionaire," and I rechanged the song to "I'm rich in friends, a millionaire." I have so many that it's unfair. So why don't you come and take a share and help yourself to my friends, to my life. So that is what comes to me. The third F for me in forward is Foxy. Now Foxy is the third F in my life, and Foxyianism, the religion, the word which I coined in 2008, calling Foxy a religion, and we took out a book called Foxyianism. And we Foxians are the ones who are responsible for the health of our women, for lowering the maternal mortality, for achieving the SDGs. It's not the government. Government can't do it alone. So we have to pitch in. So by 2030, we are on top of the world and helping the government to achieve its SDG goals. So let's go ahead, accept the challenge, a forward-looking India, a forward-looking Foxy. The fourth comes to me as W, and work is my fourth looking forward. For me, work is worship, and the place where I work is a temple, where I work honestly. And that is where I tell everyone that if you work honestly, you don't have to run after money. You just look forward, work honestly, just walk forward, the money will walk behind you and even run behind you. Rest of the life is a big give and take, and that is my mantra always. And my forward-looking statement is specially aimed at the millennials, born after 1990 onwards. Enjoy life, enjoy every moment, and live life king size. Smile without a reason. Smile at everyone and anyone you see. You don't lose anything. And smile is the best curve you have on your life. And be honest to yourself. And my last closing word is to our great host of this ONS series, Dr. Jaideep Tang. Whenever I think of Jaideep Tang, if you've been to my FB Facebook profile, I have a punchline there. And my punchline is that you were born original and don't die a copy. And that is what Jaideep Tang is for me. He's original, Foxian, he's hardworking, he's dedicated, he's sincere, he's friendly, he's ever smiling. And that is the Jaideep I know from childhood. Because his father and my mother were class fellows. And that is how we have grown up. And I have seen him grow from school to college and to coming into Foxy. And here is what I wish him. Jaideep Tang, wish you all the best in life. And I'm sure you'll make one hell of a great Foxy president. All the best to you. Thank you very much for your time.
Thank you. Thank you so much, Naren, for those kind and generous words. And as always, I am always so happy to see you, meet you. As you said, I have known you since I was a child. You were actually the first person to invite me as a faculty from outside Mumbai. I don't know whether you remember, but I still have distinct memories of that conference, which was held at Hotel Clark's in Agra. And you really went out of your way, you and Jaideep went out of your way to make sure that I was comfortable and fit in very nicely with all the other very distinguished faculty who were attending the conference. I can also tell you that when I spoke in the AICOG, hi Jaideep, good to see you. When I spoke in the AICOG that you had organized, that was one of my first presentations in an AICOG. And the topic that you had given me at that time was the role of gender in being an obstetrician and gynecologist. Does it make a difference? I don't know, you may not remember, but I still remember the topic that you gave me. And I still have those slides, in my document folder. It's always such a pleasure to see Narendra. I think I can very rightfully call him as the youngest senior in Foxy. I don't think anybody in Foxy has the penchant that he has for social media. And, people don't appreciate the effort that Jaideep and Narendra put in into Foxy. Imagine that they are out almost every weekend and they drive from Agra, they come to Delhi, they catch a flight, sometimes stay overnight in Delhi, and then they go back. And this is all after a week of working very, very hard. So I really don't know what drives you, Naren and Jaideep. I don't know what inspires you. I would not have taken Jaideep's name, but now she's sitting there too. No, Jaideep. Yeah.
We are incomplete
Thank
without
you.
you.
So it's really quite wonderful, the kind of drive and enterprise that both of you have. And I think there are two things about both of you that people don't realize. One is that you all are very, very highly successful entrepreneurs in your own rights. Running the kind of hospital that you have, and now your venture into apps, is not something which is for the faint-hearted. And the second is that both of you are extremely prolific writers. I can remember that Narendra and Jaideep came out with a book which they edited and wrote chapters almost once every 6 months or 1 or 2 books a year, which is quite amazing. I find it difficult to write one statement for Foxy. It takes me a long time to do that. I really don't know
But
how
you manage
you.
them very well.
So thank you very much, Naren, for all those kind words, generous appreciation, and I hope that you will find some time along with Jaideep to stick around for this webinar. And I'm also very happy to welcome another very iconic figure, someone who's very important in my life, Chandravati Madam. I always tell my brother and my wife and my family that Madam is one person I just can't seem to say no to. Whatever Madam says, I just have to say yes. There is no choice, at least for me, in that matter. Madam, of course, is well known to everybody. She is, as I said, absolutely iconic figure. I can see Preeti, and I remember once that there was some issue, and Preeti said that I will get Madam in the meeting, then Jaideep won't be able to say no. So very well played, Preeti. so, so it's always such a pleasure to meet Madam. Always such an inspiration. You have to see the way Madam works. The kind of number of patients that she sees. It's really amazing, Madam. I don't know where you get this motivation to do. मुझे बोलते तो मैं कल ही बंद करके हिमालय चले जाता, लेकिन you are quite amazing, Madam, and thank you for taking time out to be here. Thank you again, Narendra, for those very kind and generous words. Priyankur, I think we can move ahead with the program, and I can share my screen while you introduce me, because my first slide is my CV slide. Is that okay?
Yes, sir, that's fine. And I would just like to mention one thing over here, that I must confess over here that since Jaideep ma'am was also here, the two Jaideeps, I always got the confused with the spelling of Jay Jaideep and Jai Jaideep. But these two people were the most important people, because Jaideep ma'am, I received the first Foxy prize from her, and Jaideep sir is the first secretary when I got active into Foxy. And thank you so much for both of you being here and sharing the same platform. Thank you for that. So, next, so moving on with the scientific session, I would like to introduce the speaker, Dr. Jaideep Tang sir. So everyone knows Jaideep Tang sir is the Secretary General of Foxy, past President of the Mumbai Obs-Gynae Society, Chair of the FIGO Committee for Safe Abortion. But I must over here congratulate sir for the amendment that has come on the MTP Act, and you have done excellent work towards it. We all know it. And really, congratulations, sir. And it's definitely a great step for women ahead in this country, and for gynecologists ahead as well. So, sir, now it's the time for you for your talk. And as usual, I'm very sure the audience will be enthralled by your talk when you are talking on ectopic pregnancy. And I would also like to announce over here that we have 4,822 people who are right now logged into as delegates in this webinar. So, sir, I request you to kindly start your. Thank you, sir.
Thank you. Thank you, Priyankur. And thank you. I mean, you mentioned that JAI and JAY about Jaideep and me. And I remember Jaideep Malhotra telling me once that it is I because she always wants to do everything. And it is Y because I keep on asking, why do you want to do it? So thank you for that kind and generous introduction. But I must put on record here that this whole amendment thing was a team effort. Not only from Foxy, but several other stakeholders played a very key role. And I do believe that these amendments are going to be beneficial. And I think for a change, they're not only going to be beneficial for the women, they're also going to be beneficial for us as providers. We, of course, now need to look forward to them being gazetted after the president gives his assent to the amendments, and then the framing of rules. Sometimes, as I always say, the rules are sometimes more important than the act itself. For example, medical abortion came into India because of the rules and not because of the act. So anyway, let me stop myself because this is a topic I can speak quite a bit upon. And let me move on to the topic of today, which is ectopic pregnancy and contemporary management. What I'm going to do is give a broad overview of the contemporary management of ectopic pregnancy, and the surgical management specifically of ectopic pregnancy will be covered by Dr. Fessy Lewis in the next Wednesday's webinar. So let me begin by showing you this very interesting study that I found, a fairly recent study from 2020, which looked at the quality and utility of research in ectopic pregnancy in the last 3 decades. And I think this has become quite a if I may say so, hobby of mine. I like to now go and look at the efficacy of the literature besides reading the literature around that topic. And what I'm now quite fond of is doing comparative sort of a studies between the various guidelines which exist on a given topic. And it's always fascinating to me about how, in a lot of instances, guidelines from major organizations don't seem to agree with each other. So if you look at the quality of research which is present for ectopic pregnancy, you'll find that around 6,309 articles which are relevant to ectopic pregnancy remained, and on an average, 280 articles are published for ectopic pregnancies. And this has been more or less constant over the last 3 decades. So the fact remains that although ectopic pregnancy seems to be a problem that we have got a very good hold of or a very good understanding of, there is still a lot of literature being published on it because there are still quite a few issues which concern us. Ectopic pregnancy, as we all know, account for 2% of all pregnancies, and in most cases, the ectopic occurs in the fallopian tubes. Non-tubal ectopic pregnancies are rare, but they are potentially life-threatening, and they are potentially life-threatening because it's not always very easy to diagnose them. And I think that is something, particularly because of IVF and all the other kind of invasive procedures that we do, is something which is going to gain a lot more importance over a period of time. The incidence ranges between 5.8.3%. So it's not really something which is that uncommon or as uncommon as it used to be earlier. And again, this is very recent data from December 2020 published in Diagnostics. So these are the talking points of the presentation. We'll talk a little bit about diagnosis, management, expectant medical, surgical, and a few words about what to do when you do have a ruptured ectopic pregnancy. So the principles of treatment really could be divided into your short-term measures, which is primary treatment success, and very importantly, reintervention for clinical symptoms or persistent trophoblast, or what is called as a persistent ectopic pregnancy, and then the long-term outcome measures in terms of tubal patency and future fertility. So we were always told when we were residents that we need to think ectopic. And whenever you do a scan in the first trimester, you do need to think ectopic. And I would strongly urge you to think ectopic even if you're doing a second scan in the first trimester, because we sometimes get scans done at around maybe 6 weeks or so to establish that the pregnancy is intrauterine. And if it is a heterotopic pregnancy, you may miss that pregnancy because the ectopic is simply too small to be seen. Once you have a report saying that the pregnancy is intrauterine, you tend to sort of relax or let your guard down and then not look for another ectopic pregnancy. So whenever you do a scan in the first trimester, even if it is the second scan, please think ectopic. The things you need to look for: an adnexal mass moving separate to the ovary containing a gestational sac, yolk sac, or even a live fetus, a complex inhomogeneous adnexal mass moving separate to the ovary with that very famous ring of fire kind of a sign, a positive HCG and an empty uterus or a collection of fluid. Of course, free fluid in the POD might represent hemoperitoneum. It could equally represent hyperstimulation. So you need to keep an eye out for that patient's history. And of course, as I already said, you need to make sure that you're not missing a heterotopic pregnancy. Uh, Sometimes there is a pregnancy of unknown origin where you have a positive HCG and you're unable to see either an intrauterine or an extrauterine pregnancy. It's useful to know that if you can't see a pregnancy in any HCG above 1500, you should start strongly suspecting an ectopic pregnancy. In this kind of a case, when HCG is above 1500, between 1500 and 2500, the absence of a intrauterine sac, implies an ectopic pregnancy. Of course, These figures are not cast in stone, as I will show you a little later. And this is what I was talking about. If you compare the RCOG, RCPI, Canadian, ACOG, and NICE guidelines, you will see that they use different ranges for the discriminatory zone. And in a sense, this discriminatory zone reflects the way ultrasound is available, accessible, and done in those various countries. So, for example, if you look at the ACOG guideline, they say the cutoff is 3,500. If you look at the RCPI guidelines, they say it's 1,000 to 1,500. Be as it may, I think even if you compare across the guidelines, it is reasonable to say that at any beta HCG value above 1,500, you ought to see a gestational sac either in the uterus or outside the uterus. And if you don't see it in the uterus, you must certainly strongly start suspecting an ectopic pregnancy. If your initial HCG level is below the discriminatory zone and you are unable to see a gestation, then of course you need to repeat your HCG measurements. And remember that the minimum rise for a potentially viable pregnancy is 53% every 2 days. It used to be 66% every 2 days. However, if you use 66% as a cutoff, you will actually intervene in viable pregnancies. So now the new cutoff is 53%, in a sense doubling, or not exactly doubling, but halving every 2 days. Of course, if the HCG values are declining, then it suggests failing pregnancy. But even if HCG values are declining, it doesn't entirely exclude the possibility either of a resolving ectopic pregnancy or a rupture. Which brings us very nicely to the next part of the presentation, which is expectant management. Expectant management is something which is relatively new, because we always thought that if we see an ectopic pregnancy, we have to treat it. But we now know that we can offer expectant management as an option to women who are clinically stable and pain free, have a demonstrable tubal ectopic pregnancy. And mind you, tubal ectopic pregnancy is important, measuring less than 35 mm with no heartbeat on transvaginal ultrasound, with a beta HCG level of less than 1,000, and a patient who certainly is able to return for a follow-up. So these are your criteria for selecting patients. If you have decided to do expectant management, then you need to do HCG levels on day 2, 4, and 7 from the day of diagnosis, and then repeat weekly until a negative result, which is less than 20, is obtained. If the HCG levels do not fall by 15%, they stay the same or rise, you need to review and then seek advice, or go ahead and do an intervention with either medical treatment or surgical treatment. In fact, there doesn't seem to be any difference between following expectant or medical management. The rate of ectopic pregnancies ending naturally, the risk of tubal rupture, the need for additional treatment, health status, depression scores, and even future fertility outcomes are the same with either expectant or medical management. However, as I said, the place for expectant management is relatively limited. And these are all the agents that have in the past been used for medical treatment. We are, however, now quite sure that it is methotrexate, which is the agent of choice. And it's not a new drug. It was established in 1980s, and it's now widely accepted as the primary treatment for ectopic pregnancy. Whether to give a leucovorin rescue or not in a single dose of methotrexate cycle still remains controversial, but you could give it, we normally give it to prevent the side effects, and more so when higher doses of methotrexate is used. So which are the patients you should select for medical management? The patient should have hemodynamic stability, no severe or persistent, and these words are both important, severe or persistent abdominal pain. The patient should have a commitment to follow up, and also a normal baseline liver and renal function test. And I'll ask you to look at that table below, which is taken from this excellent practice committee document of the ASRM, which says that there are absolute contraindications for selection of methotrexate. For example, heterotopic pregnancies where there's one intrauterine, one extrauterine pregnancy. There is immunodeficiency, moderate to severe anemia, peptic ulcer disease, if the patient is ruptured ectopic or is breastfeeding. And then there are relative contraindications which could indicate that using the methotrexate in those patients is unlikely to work. When you are seeing cardiac activity, when the HCG level goes beyond 5,000, or the size of the pregnancy is more than 4 centimeters, or the patient is unable to follow up. There are two protocols for the use of methotrexate. There is the multiple dose protocol and there's the single dose protocol. We are fond of the single dose protocol simply because it means that you give less amount of methotrexate, which means that you are likely to have fewer side effects, and that is our method of choice. So the protocol is that pre-treatment you do an HCG, you do a CBC, LFT, creatinine, blood type, and antibody screen, rule out a spontaneous abortion, and if there is an abortion, give ROGAM if the patient, I mean anti-D if the patient is Rh negative. You do HCG on day 1, day 4, and day 7. And the dose of methotrexate that is used is methotrexate 50 milligram per meter square. You can give it IM, but we'd like to use it IV because sometimes the IM injection could cause a lot of pain. And the beta HCG should decrease around 15% between day 4 and day 7. One practical point I can share here is that the first HCG after the injection of methotrexate typically shows a fairly steep rise. And after that rise, the HCG starts falling down. So if the HCG rises, as long as the patient is asymptomatic, there's no free fluid, you can hold on and you can continue with the methotrexate. The precautions for physicians and patients: avoid intercourse until HCG is undetectable, avoid examination and ultrasound too much and too vigorously, particularly transvaginal, avoid sun exposure, and avoid a new conception till HCG is undetectable. There are, of course, some side effects of methotrexate treatment. Fortunately, if you follow the single dose protocol, these are usually very few and far between. It's not that methotrexate always works. It does fail off and on. And the predictors of treatment failure are the fact that there is a heartbeat, the fact that the gestational mass is more than 4 centimeters, and all the relative contraindications that we talked about later. In fact, you can see the other graph, which shows that as the level of HCG rises, the amount of methotrexate failure also rises. So if you have a patient with a little advanced ectopic pregnancy, think twice before recommending either an expectant or a medical treatment. Once you have given the methotrexate, remember that the complete resolution takes between 2 and 3 weeks, but it could take as long as 6 to 8 weeks, particularly when treatment HCG levels are higher. If declining HCG levels rise again, then you need to make a diagnosis of a persistent ectopic pregnancy. My personal advice in this situation would be to go ahead and perform a laparoscopy with either a salpingectomy most of the time. Methotrexate has been shown to be successful between 78% to 96% of selected patients. Again, it pretty much depends on the gestational age and the size and HCG value of the pregnancy. Post-treatment HSG documents tubal patency in 78% of cases. 65% of patients who attempt subsequent pregnancies did get pregnant, and the incidence of recurrent ectopics was only somewhere around 13%. So all in all, you could easily say that it's a very efficacious, it's a safe, and it is a very efficient kind of a treatment which allows you to avoid surgery. The question then becomes is how long after methotrexate should you wait before you ask the patient to start trying for a pregnancy again? Some advocate waiting for 2, some advocate waiting for 3 months. Personally, we prefer to wait for around 3 months because we are a little concerned that the tubal edema should settle down properly and then the patient can get pregnant. As I already told you, Dr. Fessy Lewis will be covering surgery on ectopic pregnancy in detail. Suffice it to say that based on the available evidence, laparoscopic surgery appears to be the treatment of choice. And then there is this eternal debate of salpingotomy versus salpingectomy. And I found this very nice article in OBGYN survey published quite recently, 2020, where they compared the RCOG, RCPI, ACOG, and NICE guidelines and looked at the various recommendations on salpingectomy and salpingotomy. And In essence, what they found was that fertility performance after a salpingotomy or a salpingectomy, with a salpingectomy, of course, in the presence of a contralateral normal tube, was absolutely the same. The advantage also of a salpingectomy was that the follow up after the surgery needed to be less rigorous because you were not worried about a persistent ectopic pregnancy. So, if you are going to do a salpingotomy, please remember that the operation is not the end of the story. You need to follow up and make sure that the patient doesn't get a persistent ectopic pregnancy. And ruptured ectopic is an emergency like no other in obstetrics and gynecology. It can really lead to a lot of panic. It can really lead to a lot of suppositions and assumptions, which are sometimes unwarranted. And therefore, it's the diagnosis which is most important. A lot of times now, patients who have ruptured ectopic are also patients who don't have access to adequate sexual and reproductive health services, and therefore think ectopic should be something which is on top of your mind when you're looking at patients like that. Large bore IV access, I've already stressed several times. Blood, and more blood is extremely important for resuscitation. There is always a debate that when the patient is hemodynamically unstable, should you give GA or should you give a regional anesthesia? I think to a certain extent, it depends on the resource setting that you're working in. If you're working in an extremely low resource setting and you are unsure of an ICU backup, it's a good idea to use regional anesthesia. But if you have the confidence and the wherewithal, then GA is a good idea because in a hemodynamically unstable patient, giving GA and intubating the patient means at least you are securing the airway quite well. There is also this debate about laparotomy and laparoscopy, which brings to mind the statement which a cardiovascular thoracic surgeon, Dr. Anil Tendulkar from KEM, used to say. And he was talking to us about vascular injuries in gynecology and managing hemorrhage in gynecology. And he said that opening the abdomen, sort of is made the point so succinctly that there are situations, very rare, where a laparotomy may be the preferred way of operating on a ruptured ectopic. When time is of the essence, I know there are people who say that I can put the varies and do a direct insertion and so on. But still, when there is a very gross hemoperitoneum, it takes time to suck out all the blood. And sometimes it does take a long time, and the patient is continuously losing blood. Sometimes, very rarely, I must say, that a laparotomy may be the method of choice for a ruptured ectopic. I would always do a salpingectomy for such a patient. I would not bother with a salpingotomy simply because a salpingectomy is going to be so much quicker and is going to make sure that the patient doesn't land up with a persistent ectopic pregnancy. In patients who have large hemoperitoneum, it's very important to remove all the clots and make sure that you give an exceedingly good peritoneal wash. It's also a good idea to remember to use warm saline for this patient, because when you're using large volumes of saline, if the saline is not warmed, that patient's temperature will fall. And if the temperature falls, you will have a more morbid kind of a patient. So these are all the instances of non-tubal ectopic pregnancies. Unfortunately, these are on the rise now, either because of interventions, because of IVF, or what have you. And there you can see the ovarian ectopic, most of the times diagnosed at the time of surgery rather than on ultrasound. Interstitial pregnancy, not a very easy diagnosis always, because you may not always be able to delineate the end of the cavity. Over here, it is seen very nicely, but you need to be a fairly good sonologist to make this distinction. There is this cesarean scar pregnancy, something which I'll talk about later. And then, of course, there is the cervical ectopic pregnancy. And you can see that beautiful 3D ultrasound picture where the cervix is bulging on one side, and you can clearly make out that that's a cervical ectopic. And I must say, this is one pregnancy where a hysteroscopy could be very useful. You inject vasopressin, and after doing that, you cauterize the fetus and then use a resectoscope and shave. The important thing here is that when you are using the resectoscope to shave the base, don't drag the pregnancy out with the resectoscope. Make sure that the electrode is always on when you're dragging the electrode out. Otherwise, you will land up sometimes opening a big blood vessel, and then that hemorrhage is really quite difficult to manage. So cesarean scar pregnancy, something whose incidence is now rising. And the only thing I would like to tell you here is that surgical treatment seems to be the method of choice for treating a cesarean scar pregnancy, particularly in a little more advanced gestation. If it is very, very, very early, then you could consider using methotrexate by injecting it directly into the sac or even parenterally. But most of the times, these pregnancies are more amenable to surgical treatment. This is a recent phenomenon which is coming up, and I could find around 7 to 8 articles on this, on myomectomy scar pregnancy. Something which was actually not very commonly seen earlier, and you can see in the article on the article on top, they had to actually manage that with a hysterectomy, whereas in the other article from China, so I don't know what to say. They managed to do a enucleation of the scar and cauterization of the base. So to conclude, we know that ectopic pregnancy occurs outside the uterus, with the most common ectopic being the fallopian tube. Most cases are detected early now because of excellent HCG detection kits, etc., that are available, and of course the spread of transvaginal ultrasound. And these can be treated either expectantly or with medical management. However, always remember that tubal ectopic pregnancy in an unstable patient is a medical emergency that requires prompt surgical intervention. Thank you very much for your kind attention. Thank you.
Thank you so very much, sir, for leaving us in awe with your talk as always, sir. Thank you so much. We have a few questions which we'll take at the end of the session. So we will first do the talk with Chandravati ma'am, and then we will move on with the question answer. So next we have another very exciting talk by a teacher of teachers, Dr. Chandravati ma'am. Ma'am is a professor emeritus, Department of OBGYN at the KG Medical College. She is a managing trustee of the Krishna Educational Foundation at Lucknow. She was the HOD of the Department of OBGYN at KGMU, Vice President Foxy, past Vice President Foxy, UP chapter OBS and Gynae in Lucknow, and OBGYN Society for the past 15 years. She was a governing council member of ICOG for the last 2 years. So we are very excited and we are waiting for ma'am's talk on calcium and PIH and extricable bond. So the platform is all yours, ma'am, and we would love to listen to you now, ma'am. Ma'am, we will request you to kindly unmute yourself, ma'am.
Please accept.
Is all right? Can you listen here?
Yes, you can. Yes, ma'am. Please go on. It's visible too.
Thank you, Priyanka, giving me this topic. I was listening to Jaideep and I wanted to tell him just half an hour back, I had a patient in my outpatient with a living tubal pregnancy, and advice was given. So you know how common ectopic pregnancy is, but I'm very happy to have this topic which was given to me. And in fact, before this topic was given, I wasn't thinking how calcium and PIH are related to each other. So I'm happy to discuss this topic today, whatever I have. Sanjay? मूवी नहीं कर रहा, मूव नहीं कर रहा, मूवी नहीं कर रहा.
मैडम आप एरो के बदले स्लाइड पे क्लिक करेंगे तो हो जाएगा मूव.
कर रहे, स्लाइड पे क्लिक कर लेंगे.
जी मैडम.
कहाँ slide का please? So we are starting with this, and we start with the hypertensive disorders are amongst most common medical disorders, which affects about 6 to 8% of all pregnancy. We all know that 30% of hypertensive disorder is caused by chronic hypertension, and rest 70% are caused by pregnancy-induced hypertension. The learning object for today's talk is, by the end of this session, we will be able to define various terms in hypertensive disorders of pregnancy, learn about nutritional intervention to prevent PIH, know about the bonding between calcium and PIH, and learn about the dose schedule and the type of calcium to be used. As we see here, preeclampsia and eclampsia is still the second leading cause of maternal mortality, and this is not here only, globally and in India, both places. It is around 14% of total mortality which we have because of the hypertensive disease of the pregnancy. Now, hypertensive disorders of the pregnancy, if we take hypertension, any pregnancy above 140/90 BP in 2 consecutive readings 4 hours apart. Chronic hypertension, hypertension before 20 weeks of pregnancy. Pregnancy-induced hypertension, PIH, we define hypertension after 20 weeks. Preeclampsia, we decide BP more than 140/90, but less than 160 and 110, with proteinuria starting from trace to 1+ to 2+. We go further, severe preeclampsia, it is BP more than 160 to 110 with proteinuria 3+ or 4+, or preeclampsia with presence of any symptoms like headache, blurring vision, epigastric pain, oliguria, and abnormal edema over face, hands, abdomen, and vulva will be termed as severe preeclampsia. Eclampsia, convulsions with BP anytime more than 140/90. We must note that convulsion in pregnancy, labor, and postpartum period should be considered eclampsia until unless proved otherwise. Before we think of adding calcium, risk factors for preeclampsia are there: nulliparity, family history of preeclampsia, obesity, multifetal gestation, preeclampsia, eclampsia, poor outcome in the previous pregnancy. All this should be taken as a risk factor. Intrauterine growth retardation, fetal death before previous pregnancy, pre-existing medical conditions like chronic hypertension, renal disease, diabetes, thrombophilias, proteinuria, antithrombin deficiency, abnormal uterine artery Doppler, and presence of notch, increased angiotensin activity, positive rollover test at 28 to 30 weeks. So when we have all this risk factor, we should be very careful that we are going to be landing up with preeclamptic toxemia. So when we come to the connection of calcium with PIH, clearly WHO issued guidelines recommending calcium supplementation during pregnancy to prevent preeclampsia. Other prominent obstetric professional organizations have also issued statement about efficacy of calcium supplement. Calcium is a low risk, inexpensive, prophylactic intervention for PIH. It is suitable for widespread implementation in community-based and primary care setting. So it is one of the easiest and cheapest way of preventing PIH by just interventional therapy. It has potential for substantial effect on the maternal and newborn health. WHO guidelines state, in populations where calcium intake is low, calcium supplementation as a part of antenatal care is recommended for prevention of preeclampsia, particularly those at higher risk of hypertension. Recommendation is based on the randomized clinical trials that found that calcium supplementation prevented 1/2 preeclamptic cases. Antenatal calcium supplementation to prevent preeclampsia. What we need to do? Ideally, assessment of the dietary calcium adequacy at population level should be done. Ideally, population with diets low in calcium should be targeted. But surprisingly, the threshold of the intake below which calcium supplement becomes efficacious still remains unknown. In many developing countries, there is a low calcium intake and maternal mortality and morbidity is on a higher side. In recent review of the dietary intake of 35 to 40 studies of middle income group countries, they found mean calcium intake to be less than 900 milligram per day. This was consistent in studies for Asia, Africa, and Latin America. So, it is reasonable to assume that mean population consumption is inadequate in most low-income group countries. Then we can also think of not supplementing calcium, but food-based approach. So besides supplementation, food-based approaches and nutrition education are sustainable and acceptable ways to increase calcium intake. But there's no data available on policy and program recommendation on food-based approaches for calcium. Meeting requirement of calcium supplements through dietary council are still remote. Now, what are the supplement formulations? What type of calcium we need to use? Several formulations are available. Calcium citrate and calcium carbonate both are highly bioavailable compared to calcium gluconate. Calcium carbonate is cheaper, but it is less absorbed when taken between meals. Calcium citrate bioavailability is not affected by meals, but is inexpensive as compared to carbonate, and more or larger pills would be needed to deliver the required dose. The doses of calcium supplement, we all know pregnancy is a state of high calcium demand. About 30 grams of calcium is transferred to the fetus. There's a bone turnover and intestinal calcium absorption increases. There's also calcium hemostasis due to hormonal changes during pregnancy. So US estimated average need and recommended dietary allowance of pregnant women between 800 to 1000 milligram. But on the other hand, WHO recommends daily dose of 1.5 to 2 gram elemental calcium, which is a very high dose. The range of doses has been tested in highest quality trials, and WHO guidelines group considered the benefits to outweigh the potential harm. This dosage range is neither minimally effective or optimal dose. Meta-analyzed lower dose have suggested comparable benefits to WHO's recommended 1.5 to 2 grams. Now, how to take calcium? The calcium dose influences the percentage absorbed. As the calcium content of the dose increases, the fractional absorption decreases. So with WHO recommendation, 500 milligram 3 times a day is the ideal way to take the calcium. But at the same time, research have found the compliance decreases when the pill taking event increases, which means if you have to take more times, most of the people do not comply with the advice and may be taking once or twice in a day. Now, the other problem is that combining calcium with other micronutrient regimes. As we all know, IFA supplementation is a part of routine antenatal care. Most health systems moving to adopt new calcium intake already have a policy to provide IFA. So, aligning and integrating both interventions could lessen the logistic complexities of adding a new intervention, which means we combine IFA along with the calcium and thus decrease the interventional programs. Now it has been reported that calcium has been reported to interfere with iron absorption. But after many more trials, the clinical effects of interaction is minimal. Hence, to agree with the compliance, WHO suggested calcium intake course of 500 milligram thrice daily and IFA separately, which means total 4 times a woman has to intake, and that is why there is times of failure of compliance. To avoid this, one-time calcium intake could be combined with IFA with minimal interactions and better compliance. So we can suggest that one-time calcium could be taken along with the IFA. The timing of supplementation. WHO recommends initiation of supplement at gestational age of 20 weeks. Pragmatically, initiation at the first antenatal visit will allow synchrony of iron and calcium supplement. Implementation of calcium supplementation with IFA is delivered through focused antenatal care, and usually the second focused antenatal care occurs typically around 24 weeks, which would be quite late for starting the calcium. Hence, we can start both the supplements at the first visit, would reduce the complexity, confusion, and delay in the starting of the calcium intake. So we can start IFA along with calcium at the first visit when the patient comes for her antenatal visit. But all is not well. Such high doses of calcium supplementation can have some side effects as well. It increases the risk of hemolysis, elevated liver enzymes, and it could also lower the platelet count. It has also been associated with postnatal bone reabsorption, but to a limited data is available, so we are not very sure about it. Higher dose of calcium has been reported to increase cardiovascular disorder risk, but validity is yet not very much confirmed. But at the end, however, advantage of administration of supplement definitely outweighs the risk. So, at the end, the research is needed to clarify timing of initiation of supplement. The research is to understand various acceptability compliance factor to make programs successful. The further data is needed to examine side effects and mitigating measures more rigorously. Preeclampsia is a prevalent globally, and prenatal calcium supplementation should be considered in low-income country setting, which can prevent maternal and perinatal morbidity or mortality. So I think I end my talk. Whatever data was there, I could present it, and I'll open to any questions if they're there. Thank you very much.
Thank you. Thank you very much, madam, for a very comprehensive and complete talk on what I know is not necessarily a very easy topic. So thank you very much, madam, for that presentation. Thank you.
Thank you so very much, ma'am. As sir has already said, it was a wonderful presentation. So we'll take a few questions before we move ahead with the session. So, sir, there's a question from Dr. Rajendra Nagarkati, sir, and he asks, when should be the second dose of methotrexate, of course, in relation to the ectopic pregnancy?
So normally you don't need a second dose if the patient selection is all right. Second dose is usually needed only if there is a persistent ectopic pregnancy. But as I said, if there is a persistent ectopic pregnancy, then I would rather operate and do a salpingectomy or remove that ectopic pregnancy surgically rather than giving a second dose of methotrexate, because what we do is we follow the single dose methotrexate protocol. We do give a leucovorin rescue after the first dose of methotrexate, but that's about it. If a second dose seems to be required, we try to go in and laparoscopically remove that ectopic pregnancy.
Jadip, can I ask one thing?
Yes, madam.
Yeah. Do you think when we need to check the beta HCG levels and then decide about the second dose? Because few patients I needed to give second dose, and at times because beta HCG when it was around say 1500 or something like that, or 1000. At times you need to give a second dose because one of my patient I gave one dose, sent her home. Her beta HCG was only 700 something,
Yeah.
and she came with ruptured ectopic on the fourth day. So that risk is there sometimes. So what do we need to do for that?
Madam, as I already said, that when the first HCG that you do on day 3 or day 4 after giving the first dose of methotrexate will always show a rise. And then it's the subsequent HCG that you do on day 7, which will start showing a fall. So in the interim, if the patient is asymptomatic and the ultrasound is okay, there is no free fluid or signs of impending rupture in terms of the patient having pain or any signs of peritoneal irritation, we avoid giving a second dose. But to tell you the truth, a rupture is always a possibility when a patient is on medical. I remember one of the first patients I did medically, her HCG was around 1800 and a twin ectopic pregnancy sac was seen in the tube. And we gave her methotrexate, we followed her till the HCG became 150. And although now the recommendations say that you should wait till the HCG becomes less than 20, I was quite happy that the HCG became 150 and told her, all right, everything is good, go to work. She went to work, and in the first day in her office, she collapsed over there with the hemoperitoneum. Fortunately, she could make it here in time. We did a laparotomy, and after around 3-4 units of blood, she was okay. So that is always a possibility.
Always there's a risk.
Yes, absolutely. But as I said, madam, I would, in those cases, I would prefer to go in and operate rather than giving a second dose. It's individual, I suppose. Yeah.
If the beta HCG titer is rising, even the first 3-4 days, yes, you said there is a rise, but if it continues to rise or it rises, but if it is still less than the cutoff value, then would you give a second dose, or?
I would operate. I wouldn't give a second dose because that clearly means that. So, for example, that let's understand how methotrexate acts. It's a folic acid antagonist, and it essentially causes lysis of the cells. If the beta HCG is still rising beyond 4 days, it obviously means that the methotrexate dose is either inadequate or the methotrexate is not acting well enough for the lysis to take place. And therefore, the chances that a second dose will act are not really that high. So I mean, and as Madam rightly said, that, we don't want to have ruptures on our hands. And I would much rather go in and operate on that patient rather than giving a second dose and risking a rupture. In case the patient is very adamant that, no, I absolutely do not want surgery, give me a second dose, I'll admit her and then give her a second dose. Having said that, even an admission is not a guarantee that I'll be able to pick up the rupture early, because the diagnosis of rupture is always post facto. You cannot predict a rupture, or even if I round on her 2 times a day, I won't be able to.
Yeah, you can't do that.
So, but still, I will insist on admission at least, so that if she ruptures, I can take action immediately.
Thank you. Meena Saman ma'am asks, what is your opinion about routine ultrasound before medical abortion?
Okay, that's a bit of a tricky question, if I may. And frankly speaking, I always get asked that question when I speak on medical abortion. So I think it's very contextual. And the whole idea is that the access to ultrasound should not become a barrier for the provision of safe abortion. So if you look at it from a broader public health context, in settings where ultrasound is available, by all means do an ultrasound. But in settings where ultrasound is not available, let that not availability of ultrasound not become a barrier for her to access safe abortion. So I have access to ultrasound, and I do an ultrasound before a medical abortion or any form of abortion. But if there is a very remote place, I mean, consider the options the patient has. No, she either can go to a qualified provider with or without an ultrasound, or she can go to an unqualified provider, for example, and have sticks or decoctions put in her vagina. You tell me which is safer. Is it safer that she gets Mifi-Meso from a qualified provider who can at least warn her about the chances of ectopic, or have these sticks input in her uterus and land up with intestines coming out of her vagina? So I think it's all very contextual. It's very difficult to make a definitive answer. So I think the long and the short, Dr. Meena, is that if you have access, by all means use ultrasound. But if you don't have access, don't let that become a barrier for that woman to get an abortion.
Thank you, sir. We have another question from Dr. Shefali from Kanpur. She asks about management in case of a heterotropic pregnancy, and also if you could throw a little bit of light about chronic ectopic pregnancy management.
First, chronic ectopic pregnancies. Typically, these pregnancies present with abdominal pain more than anything else. And if you want to get proper relief, you need to go in and operate on these patients. These are chronic ectopics. Essentially, they form something like a TO mass. And the concern here is not a rupture, which is the classic concern. It is more that the pain will not be relieved till you lyse all the adhesions and remove the ectopic pregnancy. So my approach to a chronic ectopic will always be surgery, preferably laparoscopy. For heterotopic pregnancy, it depends on whether the pregnancy is wanted or unwanted. If the pregnancy is unwanted or it's an unplanned pregnancy, then of course you can go ahead and give methotrexate, do a uterine evacuation and the standard management. If it's a wanted pregnancy, then you'll have to go in with a laparoscope and surgically treat the ectopic pregnancy. There is really no other way of doing it, because for that wanted pregnancy, if you give methotrexate, it will affect the intrauterine pregnancy equally. Madam, what would be your approach to a chronic ectopic? Chandrati, madam? Madam, chronic ectopic, what would be your approach?
Chronic ectopic, I always like to open her because what happens, there's lots of adhesions and things are there, and the fertility further is really, compromised. I yesterday opened a case of chronic ectopic, and the huge clots and everything had to be removed, the adhesions were separated. So at least she would have a chance for the next pregnancy. Many people do not open, and then you get cases of chronic pelvic inflammatory disease and keep on giving her drugs for absorbing. Patient is in chronic pain all the time. So if the mass is there, if there's a chronic ectopic, I always like to open her and remove the contents.
Absolutely. Thank you, madam.
Thank you, sir, and thank you, ma'am. We have another question from Dr. Shefali from Kanpur, and she asks, how does calcium reduce the risk of preeclampsia? Chandravati ma'am, if you could take this.
Abutta to, I don't think, I could not find how it is really affecting the thing, but only they have found that the people who are supplemented with calcium, they found that the incidence of eclampsia and preeclampsia and hypertension, PIH, was less in that population.
Perfect, ma'am. So, Jaideep sir, there's a question for you. Would you like to throw some light on multiple dose regimen of methotrexate? If you already said you don't give it, but otherwise it's a question from Dr. Shubhangi from Indore.
Yeah, the thing is that it is recommended that if you give calcium in smaller doses, the absorption is always better, which means for giving 1500, you have to give her 500 3 times a day, what WHO has suggested. Now, if you give her 3 times this and then you do not want to combine iron with calcium, then you give a 4th dose of iron for that woman. And that was the problem of compliance. So we said that you cannot increase the dose of calcium, make it 1000 morning, 1000 evening, because that would be poor. So you have to have a 500 3 times a day, or maybe 500 twice a day, and have an iron combined with one of the calcium doses so that the compliance and adherence to the suggestions would be with the patients.
Ma'am, and when would you like to start the calcium dosage? I mean, this is another.
Usually they suggest about 20 weeks, but what I said that in our program, the IFA is, iron supplement is given at the first visit. So we cannot call the patient again to come for the calcium supplementation, which would be rather difficult. So advise the calcium at the same sitting when she is advised at the first visit about the IFA and combine calcium with the IFA. Start from the first visit, maybe 12 weeks, maybe 14 weeks, maybe 16 weeks.
Thank you so much, ma'am. Sir, would you like to comment on the multi-dose?
Well, since I don't use it, I won't, but the ASRM document which I referred to actually gives a protocol for multi-dose use where you can give up to 4 doses of methotrexate and keep on following that with leucovorin rescue. But I don't know. I just feel that one of the problems with methotrexate really are the side effects, and the side effects of methotrexate are dose dependent. And if you select the patient correctly or you are conservative in your patient selection, you probably will not have too many failures with methotrexate anyway. So I don't really, those are the reasons I don't really prefer multi-dose methotrexate regimen.
Well said, sir. We'll just take a couple more questions before we move on to the next session. So this is
Priyankur, I just wanted to add here that once I had a patient of methotrexate toxicity. She was referred to me by a general practitioner, and it was actually they had given her 3 doses at 3 days intervals somewhere in Shahapur, which is a little bit of a village area, and she had come with severe glossitis and bleeding from the gums and all that. So we had to manage conservative. So I think what Dr. Jaideep says is very true. I think we should try to avoid the second dose as much as possible, because you never know when she can have this toxicity problem.
Thank you, sir, for your input. Sir, there's a question from Dr. Nitya from Erode. She asks, is there any medication which has to be given along with methotrexate?
No, not really, unless you consider leucovorin rescue, which is given on the next day. There are some people who are fond of putting some multivitamin in an IV pint and giving it along with methotrexate, but it's not really recommended.
Thank you, sir. And the last question from Dr. Shashikala from Salem. She asks, heterotopic pregnancy with the lady already underwent spontaneous abortion. What would be your views? How do you pick up and what next for the patient?
So that's exactly what I was mentioning, that once you have a documentation of an intrauterine pregnancy, you do tend to be a little complacent and not look for a adjoining ectopic pregnancy. And that is why every time you do a first trimester ultrasound, whether it is for the initial scan to look at the location and health, or it's the subsequent scan in a abortion to look for completeness of abortion, you should at least take a look at the adnexa to make this diagnosis. If you have, however, made the diagnosis, then you have actually completed the most difficult part of the process. In that you have identified that she has an heterotopic. And in this kind of an instance, again, I would prefer a surgical option. I wouldn't really prefer a methotrexate option or a conservative management, simply because it will be very difficult to know the exact rate of fall of beta HCG. You have here a situation where a patient had an intrauterine pregnancy and aborted that, and then you have an ectopic, and I won't know how quickly or how it will fit into this concept of beta HCG falling at 52% every 2 days. So I simply won't be able to make a good prognostic kind of a marker, and therefore for such a patient, I would certainly prefer a surgical treatment.
Thank you so very much, sir. And thank you, Chandravati ma'am, for your inputs, for your talk, and for your comments. Thank you so much.
And Priyankar, before we move on to the video, can I just say how thankful I am to all the moderator and the panelists for being a part and making sure that they attended this session.
Yes,
The session is going to be moderated by Preeti, easily one of the most hardworking Foxians I have seen in my more than 22 years that I have been in Foxy. Preeti has this amazing ability to conceptualize and get projects done on time. A prime example is the Vistrit project, which she is now in the process of concluding. And of course, that magnificent AICOG along with Chandrati Madam and the entire Lucknow OBGYN Society we saw, and was, I think, probably one of the last conferences we attended. Thank God it was a memorable conference, which has taken us through almost a year of pandemic. And then, of course, panelists, my very good friends, Dr. Meena Samant from Patna, Raju, somebody again like Naren, I have known since I was very, very, very young. And of course, a very dedicated chairperson for Foxy. There is Ashwini from Pune. Ashwini, thank you. You could make it this time. I know last time you had some issues with connectivity. And then there is Ritu, who is an incoming chairperson from whom great things are expected. Thank you all of you for making it. I think Dr. Preeti Jindal and Dr. Kirti Dubey cannot make it, and Kalyan will try to join in between. But I'm sure Preeti will have her hands full with all the panelists and their expert knowledge and inputs. Preeti, thank you very much for making it. I know that there were some challenges for you, and I really appreciate that you sort of tried to overcome them and join us. Priyankar, if we could have the video, and then we'll hand it over to the panelists.
Thank you so much, sir. So no scientific session happens without academic partner. So we'll have a short video from our academic partners before we move on to the panel discussion. Saurav, can we have the video, please?
The triangle of B complex is essential for pregnant women in their dietary process, as while conceiving, women find it difficult to produce adequate levels of vitamins. With external supplements, they get their required dosage, which is ready for absorption and utility by the body. Vitamin D also is most crucial in pregnancy and lactation. For prevention from adverse outcomes, future risk to health of child, and maternal and fetal health during pregnancy. European Society for Pediatric Endocrinology confirms vitamin D3 2000 IU per day ensures adequate vitamin D status in pregnancy and early infancy. Vitamin D3 supplementation helps achieve the sufficiency and can be taken for a long duration. Calcium also plays an important role in pregnancy as its twofold requirement increases. Adequate maternal health is needed for fetal bone health, and as per the BMC Public Health article, calcium supplementation during pregnancy reduces gestational hypertension by 45% and preeclampsia by 59%. Effective management of pregnancy demands supplementation of prenatal vitamins. This supplementation provides protection against various defects that can occur during pregnancy. Shellcal XT provides protection against neural tube defects. It reduces the risk of preterm birth and congenital heart diseases. Shellcal XT contains 1250 mg of calcium carbonate, which is required to maintain maternal skeletal calcium. 2000 IU of vitamin D ensures adequate status in pregnancy and early infancy. Shellcal XT has 1000 micrograms of L-methylfolate. Journal of Clinical Pharmacology and New Drugs confirms that L-methylfolate helps in decreasing the risk of NTD by 72%. The methylcobalamin at 1500 micrograms improves pregnancy outcome and maintains normal folate metabolism. The additional pyridoxal 5-phosphate at 20 mg reduces nausea and vomiting in pregnant women. From preconception, pregnancy to lactation, Shellcal XT is a world-class product for vitamin supplementation. Shellcal XT has special coating technology and vitamin D3 in stabilized form. Shellcal XT helps to reduce the pill burden. Dosage of Shellcal XT is 1 tablet once a day. Each ingredient in Shellcal XT is coated separately, so there is no drug-to-drug interaction. Shellcal XT scored tablet gives dosage convenience. A healthy start leads to healthy mothers, and healthy mothers make a healthy generation. After all, every pregnancy is precious.
Thank you so much, Saurav. So now we come to the most exciting part of this session, the panel discussion. We have the moderator, Dr. Preeti Kumar ma'am. She is the chairperson of the Safe Motherhood Committee, FOXY. She was the organizing secretary of the wonderful AICOG 2020, the last AICOG that we enjoyed a lot. She has received the Appreciation Award by FOXY for execution of AICOG 2020 as the organizing secretary. She has been organizing secretary of many, many conferences and has received a number of awards for various achievements that she has already made. So I hand over the session to Preeti ma'am to take over from now with the self-introduction of the panelists, and from there on we move ahead with the panel discussion.
Thank you, Priyanka. Should I share my screen? So are the slides visible?
Yes, ma'am, they are, ma'am. You're audible.
Thank you so much. Thank you so much. At the outset, I would like to really thank Dr. Jaideep Tank and Dr. Parikshit Tank, and of course, this dynamic young person, Dr. Priyankur Roy. He had been so kind in approaching us for these webinars. Thank you, Priyankur. And Dr. Jaideep, in fact, we would like to express our gratitude from the Lucknow OBGYN Society for helping us out in organizing such a wonderful conference. So a lot of accolades to you as well. And the same thing I want to reciprocate. When I did all the activities of Safe Motherhood Committee, without your support, it was just not possible. So thank you for giving me this opportunity, and really want to congratulate Dr. Jaideep Tank and Dr. Parikshit Tank and the entire team for having such beautiful and academic sessions O2S in OBGYN. So we have the wonderful panel here, the very knowledgeable panel, and unfortunately, Dr. Kirti Dubey, Dr. Preeti Jindal, and Dr. Kalyan will not be able to join because of some emergency. But we have other panels on board. So I'll request everyone to introduce themselves. Dr. Meena Samant.
Hi, good evening. I'm Dr. Meena Samant from Patna, Chairperson Clinical Research Committee, FOXY. Thank you for inviting me.
Thank you, Meena. Dr. Rajen.
Good evening, everyone. I'm Dr. Rajendra Nagarkatti from Mumbai. I'm the chairperson of the FOXY Midlife Management Committee and the EMOGS Midlife Management Committee. I wish to thank Dr. Jaideep Tank and the team, and particularly today's moderator also, Dr. Priyankur, for inviting me to be a part of this wonderful program.
Thank you, Rajen. Now, Dr. Ashwani. Dr. Ashwani.
Sorry, ma'am, I missed the question. I'm really sorry.
You have to introduce yourself, Dr. Ashwani.
Okay. Yeah, I'm Dr. Ashwini Kare from Pune. Currently, I'm the secretary of Pune OBGYN Society, and I'm the Young Talent Committee chairperson of AMOX for 2 years.
Thank you, Ashwani. Thank you.
Thank you,
Dr.
ma'am.
Ritu Khanna.
Good evening. I'm Dr. Ritu Khanna from Varanasi. I'm the ART consultant and the chairperson-elect for the FOXY Food and Drug Committee. And thank you so much to Dr. Jaideep, Dr. Parikshit, Priyankur, Dr. Preeti for having me here.
Thank you so much. And Priyankur, just give me a hint when the time is over. We have 40 minutes, so I'll request the panelists to be very concise to the discussion, and the answer should be very crisp. So vaccination is the act of introducing vaccine into the body to produce immunity to a specific disease. And immunization is a process by which a person becomes protected against a disease through vaccination. And most of the times the vaccination and immunization are used interchangeably for the same thing. So the rationale is that the pregnant woman is at increased risk of severe illness from some vaccine preventable illnesses. We need to prevent the neonate, so passive immunity by transplacental transfer of antibodies. likelihood of disease exposure is high in pregnancy. Infection would pose a greater risk to the mother, and infection would also pose a risk to the fetus, and vaccine is unlikely to cause the harm. So these are the topics that would be discussed today. One is the preconception vaccination. Second one would be pregnancy immunization schedule. Third one will be special situations that we encounter during pregnancy. Of course, a lot of discussion on COVID vaccination in pregnancy and the postpartum vaccination. So the first one is, I think I'll start with Meena, because she is in one of the public sector hospital, big hospital. Mrs. X, 25 years old, married for 1 year. She comes to you for preconception counseling, and she is planning to conceive in next 3 to 6 months. So my question is, do you ask any, for that matter, do you get such kind of a patient? Because usually they come when they're already pregnant. So do you really get such kind of patients in your day-to-day practice? And if yes, what counseling would you advise to these patients?
Fortunately, fortunately, now we've started getting ladies who are planning to get pregnant, and they've heard of folic acid, they've heard of, and they may be having certain medical conditions. They come for that, and that is the window of opportunity which we could include to look at certain other preventable conditions. In a specific history, if you ask me, as far as immunization is concerned, not particularly. Though we would, when we get such patients, we would like to test them for rubella, because that is one condition. If they are non-immunized, they could be immunized before getting pregnant. Okay. And because we know the implication of this infection if they get it in pregnancy. So that is one thing that we include, and especially if they're coming for infertility treatment and so on. Then now also from our side and also from the patient side, they started asking for cancer vaccine. Okay. So that is one positive thing, though that is not particularly meant for pregnancy, but yes, the awareness is rising, and we can talk about it. And if they're not planning pregnancy right away, we could, think of giving it to them.
Okay, so cancer vaccine and rubella would be the history part of in such patients. Dr. Ritu, you are doing private.
I just wanted to add that we would like to ask her about all her childhood immunization also.
Yes.
Because maybe she's left and we want it to be a catch-up vaccination sort of a thing.
Okay. So rightly pointed out by Dr. Ritu. Dr. Raju, would you like to add something?
Here again, influenza, yes, because it's an annual vaccine, and especially those with high risk of, those having asthma and all, they would be taking it. It would be there in their protocol, and that is something we could discuss.
So
the history of all high risk conditions, I think diabetes, asthma, and all should be ruled out.
Yeah, they should be ruled out, but we have to discuss only about the immunization part, and we need to highlight these MMR or rubella vaccine, varicella,
these are all
HPV. And yes, Raju.
I was saying that these are all basically live vaccines, so they cannot be given during pregnancy. Okay. But if once it has been given, then you have to wait for a minimum of 1 month before she conceives.
Dr. Ritu, do you wait for 3 months? Because earlier there was a guidelines that you have to wait for 3 months, and now
earlier guidelines were for 3 months, but now it is
basically if she is taken some varicella or MMR, then I would like to wait for 3 months. But with HPV vaccine, no, she could go even earlier with it. Just after the shot, she could move in for that, and even.
So, Dr. Ashwini, suppose if the patient conceives, you have given an influenza vaccine or maybe MMR, you have given the vaccination to a woman, and she conceives, would you like to terminate this pregnancy? Because these are all live vaccines.
Right. So this is a very common condition. It happens at times that the patient has just taken a rubella vaccine and she's conceived. So there's no, the pregnancy is basically not a contraindication for this, and you should not ask her for termination for sure. So because the risk is all theoretical, you can always counsel her regarding the risk and benefit of this vaccine.
Okay.
Termination, surely no.
It's a very valid point, yes.
Dr. Ashwini, you said rubella. Do you prefer giving MMR or rubella to these patients, to these young ladies?
If the childhood vaccination is done well, then I would prefer giving a single shot of rubella.
Okay. So, and what about HPV? Suppose you have given 1 or 2 shots of HPV and she conceives?
Then also no.
We can just stop the other shots that she needs to
Can
take,
be done in the
and that could be
postpartum period.
deferred
Can be
to
done
after pregnancy.
postpartum.
Yeah.
I would like to have the opinion of all the panelists. We have 4 panelists here. Would you like to prefer, suppose the patient is not immunized earlier with rubella, would you like to give rubella or you would like to give MMR?
My
We have the
understanding
opinion
is
from all.
that
First,
we have
one by one.
MMR vaccine available here, so that's
Yeah.
what we give.
Okay, Meena gives MMR. Dr. Raju?
Yeah, MMR. I would prefer MMR because of the additional protection from measles and mumps.
Dr. Ritu?
Yeah, MMR. I think even in the childhood, they've changed from measles to MMR also now.
Okay, so we are on the same page. CDC emphasizes that use of MMR vaccine is more beneficial for the mother and the child, and MMR should not be administered to the pregnant woman. And because the risk of fetus from administration of live vaccines cannot be excluded for theoretical reasons, women should be counseled to avoid pregnancy for 28 days after vaccination. But even if she conceives, it is not an indication for termination of pregnancy. So, Dr. Meena, can you just tell us the general guidelines for vaccination in pregnancy or immunization in pregnancy?
We're basically giving tetvac, tetanus toxoid.
No, I'm just talking about not talking about the vaccine. I just wanted to ask about the general guidelines about the vaccination in pregnancy.
Okay. So the live vaccines we are not giving
Yes.
in pregnancy.
Yes.
We give those vaccines that have been,
Inactivated.
the word is
Inactivated.
So we give,
inactivated, attenuated vaccines we are giving.
Right.
And yeah, so that's it.
Yeah, Ashwani, anything else?
And there are, and in only some specific situations, we may have to give other vaccines.
Okay, we'll discuss about that, Meena. Dr. Ashwani, anything else you want to add?
And
How many of you really take? How many of you really take the history of immunization when the patient comes in the first antenatal visit? How many of us, or we start counseling about the vaccination in pregnancy? Dr.
So
Ritu.
the first visit is generally big history, madam, because the entire history has to be taken that time.
Yes.
So it's more of a chit chat during the first visit. So definitely it goes up till the immunization history.
I think it should be a part of the first visit.
So
we make a kind of a timetable to the patient for each, including investigations.
We'll come to that.
The patients are also very well informed these days, madam, because the minute they come into your clinic, they ask you what vaccination should I take, which one is to be taken right now in the first trimester, which is there in the second trimester.
Yeah, so
if we talk to them, Dr. Preeti, if we talk to them, I think they come out with all their things, they've taken this and could this be possible?
Okay. Right, Dr. Ritu, I just want to emphasize that pregnancy should be ruled out prior to immunization in a woman in childbearing age. Immunization history is very important part of the first antenatal visit. Live viral vaccines are contraindicated, but the risk is largely theoretical. But if a patient receives the live vaccine, it should not undergo termination, and non-pregnant women should delay pregnancy for at least 4 weeks. So these are all the list of vaccinations that you can do before pregnancy. And we will come a little bit late about what vaccination schedule you should follow in pregnancy. So what about the COVID vaccination before conception? Dr. Ritu, you are doing a lot of IVF and infertility management. So do you really advise COVID vaccination to the couple before taking up for the infertility management?
I think actually it depends upon the community transmission which is there. If it's a high community transmission, yes, she should take it before pregnancy. I think all the vaccines for the COVID before pregnancy would be definitely better, because as per the data, we still do not have much of the data of the pregnant patients.
So Amina, anything else, or Dr. Ashwani, would you like to add? Because these are the basically 3 questions that have been put up in ISHRE guidelines in 2021. Should men and women should receive a COVID-19 vaccine before attempting conception? Or should couples who receive COVID-19 vaccination postpone conception? And if yes, how long? And should a pregnant woman, that will take up later. So these are the 2 questions that they really want to highlight. If any couple is willing to undergo the treatment for infertility, or they want to conceive, is COVID vaccination must? Meena.
Madam, there are no clear-cut guidelines regarding the COVID vaccination and pregnancy, but they have said that if the patient has inadvertently taken the vaccine and is pregnant, she should not terminate the pregnancy. it is still considered safe because COVID with pregnancy has a lot of other morbidities and mortality associated.
So Ashwini, what is your practice in your setup? Are you advising if the patient comes for the infertility treatment or they want for the preconception counseling, are you advising them to have the COVID vaccination?
Yes, yes, definitely, madam, because taking a COVID vaccine these days is very important, because if your number has to come basically for this vaccine, it has to be made available, and those who have taken a first shot are waiting for their second shot. So yes, definitely, because conception treatment can still wait or can get postponed for a month or two.
Okay. Meena,
At the same time,
Look
Dr.
here,
Preeti,
in our place, the vaccine is, it was initially available only for the medical fraternity, so the nurses and all. So we had a lot of young nurses and young doctors who are trying for pregnancy or planning for pregnancy, ringing us up what to do and what not to. In fact, some of them were, and there was quite a lot of uncertainty, and they just where they were asked to take, because they were in the medical, so when everybody had to take, they were taking letters from us that since they may be pregnant, they're taking treatment that they may be asked not to take, because in some institutions it was kind of compulsory for them to take if they were in the medical. For the general population, I mean, it's still age based, no, before 80, 60 and all that. They've not come for the general population. It's not available here still. So it was limited. It's a kind of limited situation here for us. So it's not a general population, but yes, there is skepticism, and there is because it's not been recommended for pregnancy. So those who are taking infertility, they are sort of, because it's informed, it is their choice.
Okay.
From our side, we would tell.
Okay, Meena, I got your point. Raju, would you like to add something?
Yeah, I would like to say, as it says here, that Eshrey suggests that you don't have to give the vaccination before you start the treatment.
Yes.
But if you do give the vaccination, then it's preferable to wait for about 2 months before you start the treatment once again. So give her a gap of 2 months so that she finishes the 2 doses.
Yeah.
And to the subsequent 15 days, because it takes 45 days for complete
antibodies to form. Yeah. Okay.
Yes, after the first dose.
So if the patient if the patient is willing, you can just opt for the vaccine. And if she's not willing, the couple is not willing, then you cannot stop the treatment. You can just continue on.
Whatever you're giving the influenza vaccine, the antibodies get percolates to the fetus also, and the fetus is also protected.
So I got your point, Rajen. You just want to counsel her for 3 vaccinations. One is TD, the second one is Tdap, and the third one is influenza. So
yes.
Meena, what is your practice at your hospital?
Yeah, we are using tetanus toxoid and then the Tdap. Or if she needs only one, she's become pregnant too soon, within 3 years, then we give her single dose of Tdap. And influenza vaccine, every pregnancy we are giving one. If she has even taken within 6 months in pregnancy, we giving her.
Is it
one.
available in your hospital? Meena, it's a little bit
Yeah.
costly. Even Tdap is costly and influenza vaccine is also costly. Is it available?
It's patients buy.
Okay,
We
okay.
advise those who
Okay.
want to, they buy for themselves. The hospital doesn't pay for it.
In fact, the second, the new influenza vaccine, which is the
We'll come to that, Rajan. Let us have the opinion of Dr. Ritu and then Ashwani.
Yeah.
Is your opinion differ? Besides these 3 vaccines?
Yeah, but when she comes for the first VD, and preferably if it's a second trimester or a 12 weeks or so, we give the first TD, and 4 weeks later we give the second dose, and we give the TD booster at 27 to 36 weeks.
So you are not giving Tdap?
We are giving TD. No, I'm giving TD.
You are giving TD. So 3 doses of TD. Dr. Ashwani, what is your practice?
2 doses of TD and 1 TD vac. I mean the booster with the pertussis.
Okay, okay.
Tdap.
So these are basically, I just wanted to highlight these very important 3 vaccines which needs to be given to every pregnant woman, and then other vaccines depending on the risk and the conditions, special situations. Influenza, of course, yes. TD, yes, and then Tdap. So we'll just take up one by one. Influenza vaccine. Can Dr. Raju tell us what are the effect of influenza in mother and fetus, and are pregnant women high priority group for vaccination?
The effects on the mother basically is that whatever the symptoms happen, they are little more vigorous or little more severe if the patient gets. You're asking about the influenza per se.
Yes.
Yeah. So if she gets influenza, then it is more severe than in a normal population because of the decreased immunological status.
Yes.
And also she gets more prone to complications like probably a preterm birth, even sometimes maybe IUGR in the fetus. So therefore giving the influenza vaccine definitely has benefit, I feel.
Okay, Dr. Ritu, anything else you want to add?
I think the same. She's more prone to abortions and preterms and all. So that risk we will not let her take. And so we would like to vaccinate.
So there are a lot of maternal and fetal complications. The severity of the illness is much more in pregnant women. The prevalence may not be high in pregnancy, but the severity of the illness is much more, and there are a lot of fetal complications. So the next question was, is pregnant women high priority group? Yes, WHO has given the statement that pregnant women are highest priority group for vaccination in any trimester. So this patient who took the vaccination 6 months back, when would you like to give the vaccine now?
Preferably that would be near term, madam. It would be in the 3rd trimester, as close to the delivery as possible, because that would provide a maximum protection to the fetus as well.
Yes, yes.
28 weeks, I think, would be the recommended.
28 weeks.
28 to 36 weeks. Yeah.
So do you wait, Dr. Ritu, do you wait for the new strains, because these vaccines, they keep on changing every time? So do you wait for the new vaccine to come up, or you just give whatever vaccine is available in the market?
Actually, it's an antigenic drift. We will really not come to know what strains and all. It's better to vaccinate them rather than waiting for the seasonal variation or the drifts to occur and the strains to change.
Okay. So definitely vaccination has its role. Immunization generates a robust immune response in the pregnant mother, and similar to non-pregnant healthy women, and effective protection from the 3 vaccine strains. Now, the question is, Meena, we have different kinds of vaccine, influenza vaccine, trivalent vaccine, inactivated trivalent, and we have inactivated quadrivalent. So which vaccine you like to give to these patients?
Well, practically speaking, what is available in the hospital is what we would be giving.
Okay.
But yes, quadrivalent, if it is available, then that is the preferable one.
Okay, Raju, which one is the preferred one? Is it a trivalent?
So far, I was giving the trivalent one because that was more easily available. The new vaccine has just come into the market, and although they say that there are not too many studies with the new vaccine, but still, yes, Foxy recommends that, even the quadrivalent vaccine is safe enough and can be given. But it is again little more expensive than the trivalent. So I think cost is also even in my practice. I don't make it compulsory like a tetanus or a TD vac.
Okay.
I leave it to the patient. I tell them that this is recommended by Foxy and it is better for you to take it, but it's your choice because it is a little expensive. So we tell them that and then we prescribe it so that it's not a sudden load on them.
Okay,
So,
Ashwani, Foxy recommends that influenza vaccine should be given at 26 weeks, but all international recommendations have emphasized safety in all trimesters. So what is your take on this? What is your practice? Do you give it beyond 26 weeks or you can give it in any trimester if you want?
it can
Actually,
be
it
given
can be
in
given
any
in any
trimester.
trimester, but I recommend giving it in the third trimester.
Okay,
Because that will
Ashwani gives it in third trimester. Dr. Ritu, when would you like to give?
The same after 26 weeks.
Okay, Meena,
generally
you also
given
give.
with the TDAP for
Well, if there's a there's pandemic or this, then if
It
it's
can be
seasonal,
given, yeah.
one
It can
has
be
to.
given in.
It can be given earlier, but I feel first trimester I want to avoid anything extra.
I prefer the 28 weeks because it protects the third patient from the influenza in the third trimester, particularly because if she gets influenza very close to term or during labor, it can be very, very, nasty. And so therefore 28 weeks, it protects the mother for those 3 months.
So, okay, Rajen, I got your
Protects
point,
the
but
first the fetus.
I'll ask you another question. This is
Okay.
ACOG recommendation that influenza vaccination is essential element of preconception, prenatal, and postpartum care because pregnant women are at an increased risk of serious illness due to seasonal or pandemic influenza. It is critically important that all obstetricians advocate and provide influenza vaccine to their pregnant patients every season. And influenza vaccine can be administered anytime during pregnancy, before or during the influenza season. Now, question to you, Dr. Rajendra. Can a pregnant woman who has received this influenza vaccine, can she get an infection of influenza?
Yes, possible because there are, like you said, many different strains. And in a particular pandemic or an epidemic, we cannot say which strain is active. So she can get the infection, but generally, once she's been vaccinated, it has been seen that the severity of the disease is less,
Yes.
chances of hospitalization is less, and the overall effects on the fetus, the overall complications in pregnancy become less. So
Okay.
that's the main advantage.
So point well taken, Dr. Rajan. And both the vaccines, whether it is a quadrivalent or it is a trivalent, the only difference is that the trivalent has 2 strains of influenza A and 1 strain of B. And quadrivalent has 2 strains of B, that is Yamagata and Victoria. So both the vaccines, whichever is available, can be given to the pregnancy. So suppose if the patient declines vaccination, this I just read it in ACOG, but usually we don't write on the paper. We don't mention it on the paper that the patient has declined vaccination, and refusals should be documented in patient's prenatal record. So I wanted to highlight this point. That is why I have put it here. This is in the ACOG recommendation in 2018. If the patient declines your vaccination, it should be clearly mentioned on the record. So next question, Dr. Ritu, can we co-administer both the vaccines, like if you want to give Tdap or if you want to give influenza? Both together.
Yeah.
Patient stays
It's
far off. Yeah.
It's only with the live vaccines that we need to have a difference of around 2 weeks. And these two vaccines, yes, could be given together.
Meena, what is your practice? Can you administer both the vaccines
Yeah,
together?
as per my knowledge, we can administer two, but in the two different arms.
Different arms. Yes. Rajen?
Yeah, we can give them. It has been recommended also that it can be co-administered together, especially Tdap and influenza can be given together.
So both the vaccines can be given in any trimester, especially during epidemics or pandemics, practically after first trimester, and co-administration of inactivated vaccines during pregnancy or postpartum is acceptable. So both the vaccines, Tdap and influenza, can be given at the same time. So now coming to the Tdap vaccine, we all know that pertussis is more commonly called the whooping cough, and it is highly communicable respiratory infection caused by gram-negative bacteria. And transmission is airborne, and most of these infants are prone for infection in first 2 months of life. So 90% of the infants under 2 months of age with pertussis require hospitalization, and 75% of pertussis related deaths occur in infants under the age of 2 months. And you will be surprised to know that The parents are the most common cause of the transmission of infection, and DPT vaccination usually starts after 6 weeks. So we need to just cover the mother so that the baby is also protected. So what do you understand by cocooning? So this is a concept that has been given with DPT. Ashwani, will you like to take this? Ashwani?
Yes, ma'am. I
Tdap.
have not heard about this concept.
Okay.
This is basically giving the Tdap vaccination to the immediate relatives or the family members of the newborn, like the mother-in-law or the patient's sister, etc., who are going to be handling the child.
Yeah.
Yeah. So to protect the child from getting the pertussis from them.
So cocooning is basically a strategy of vaccinating pregnant women in third trimester or immediately postpartum and all close contacts of infants aged less than 12 months with Tdap to reduce the risk of transmission to infants. But practically, if you see, it is just not possible. It is possible to vaccinate a mother. It is not possible to vaccinate the entire family who is handling the child. But cocooning concept has been mentioned that whosoever is looking after the child should be vaccinated, and ideally they should receive Tdap at least 2 weeks before beginning close contact with the infant. Now, coming to this question again, how many of you stick? I think Raju said, who said Titvac only? Dr. Ritu said Titvac?
No, I said,
Oh,
yeah.
okay,
Dr.
okay.
Ritu's
So
going
Meena.
for TD. Dr.
So how many of us are still hanging on to TT? Meena is giving TT in her hospital. Dr. Ritu, you are giving Tdap. You mentioned Dr. Ashwani.
And the first dose we generally give as TT, and the second dose we give it as Tdap in the third trimester.
Okay, so you are giving 2 doses. And what about Dr. Raju?
Yeah, I give first dose as TD, and the second dose again I recommend them Tdap. But if she's not very affording or something, then we give them the second dose also as TD, because there is a cost difference. It's almost 1100 rupees. So therefore, if the patient is affording, especially last year with COVID, there was a lot of financial issues. So we had to ask them first and then give so if they are willing, then yes, Tdap would be the preferred second dose.
So Tdap is recommended beyond 20 weeks. And it has been said that if you vaccinate a woman in third trimester, there is the increased load of antibodies that are formed and the baby protection is better. So that is why we give influenza vaccine and Tdap vaccine usually beyond 27 weeks of gestation. Now, regarding the TD and Tdap, TD is combination of vaccine which contains tetanus and diphtheria, and Tdap is a combination of vaccine that contains tetanus, diphtheria, and acellular pertussis. And the amount of antigen is less in this, and activated protection against tetanus, diphtheria, and pertussis. There is no live vaccine component in this. So TD recommendation is that ACOG has given in 2017 that the recommended schedule for this vaccine series is you have to give 3 doses of TD, 0, 4, and 6 to 12 months, and 1 dose of TD should be replaced by Tdap. So these are the recommendations by ACOG, but at least if you are having a pregnant mother, the first thing what I do in my practice is after 3 months, I give her a dose of TD, and then give her a dose of Influvac or influenza. And then at 27 weeks of gestation, I gave her Tdap. So this is a kind of a practice I'm doing in my practice, but the government has also given a guideline that TD replaces TT, and we should stop using TT. But I must confess, yes, I must confess, I was also using TT and Tdap in my practice, and thanks to Dr. Jaideep, I read through the literature, and today only I purchase TD, and now we will start giving TD in all the patients. And this is not a costly this thing. It's a very cheap this thing vaccine. So TD can be very easily given. So safety of TD is both TT and TD have been used extensively in pregnant women worldwide to prevent neonatal tetanus. They have not been shown to be teratogenic, and the safety of ACIP suggests that TD should be given beyond 20 weeks of gestation. Is there any condition, like is there any special condition where you can give Tdap earlier also? Dr. Ritu or Dr. Meena or Raju, anybody can take up this question.
Sorry, what was the question? Sorry.
Can you just give Tdap in earlier part of the pregnancy also? Is there any situations where you can give Tdap earlier also? So this is a normal, we give it at 27 to 36 weeks. And at least 2 weeks prior to the delivery, you should give Tdap as long as that is there. But is there any special situation? Ashwani, you can take up this question.
Maybe if we're expecting a preterm delivery.
If a patient requires any wound management and you want to give a TD booster,
it can be replaced by Tdap.
Tdap. It can be replaced by Tdap, and then once the patient has received Tdap, then there is no need to repeat the Tdap. So this is, this is also correct. You have to note that if the patient has received Tdap earlier also, but for every pregnancy she has to take Tdap in the pregnancy. So the vaccination schedule will be like what I have mentioned: Tdap, Influvac, and then the 27 to 36 weeks you can give the Tdap. So practical schedule I have mentioned: first set of vaccine as soon as more than 12 weeks, TD if not available, TT, of course, influenza vaccine, and the second vaccination Tdap if not available, then TD can be given. In case of influenza vaccine has not been given earlier, you can give both the vaccines together. Now coming to the special situations. Now, can we recommend hepatitis B vaccination in pregnancy? If need be, if you think that the patient is a high risk, she can get infection, she can get infected with hepatitis B vaccine, hepatitis B infection. Can you give vaccine hepatitis B?
It can be given.
Yes.
Only when the advantage or the benefit is more than the risk.
More than
Only there is a high risk situation.
She's in contact,
So there's
close contact with hepatitis
it's the
B.
recombinant, so there's no contraindication as such for the vaccine, but only high risk situation.
Only high risk situations. Now this is another case. Mrs. Y, aged 30 years, had a street dog bite. ये बहुत common होता है, कुत्ता काट लेता है, नहीं तो घर ही के काट लेते हैं. She visits at your clinic and she is 24 weeks pregnant. She needs your opinion regarding rabies vaccination post exposure. Dr. Ritu, would you give rabies vaccination to this patient, to this pregnant woman?
Yes, we have to just see what are the risks, and if they outweigh the benefits, yes, she can be given the rabies vaccine.
Meena?
Yes, we definitely. It's a street dog. We do not know about the immunization of that dog, definitely, because we know that rabies is a fatal condition. So we would recommend immunization for such a patient.
Okay, so inactivated viral vaccine, and it can be given in pregnant patient. And then yellow fever is again what we talk about, because when we went to Rio, everybody took yellow fever vaccine. So it's a risk versus benefit, and it can be given provided the pregnant woman is at a high risk. Now, postpartum vaccines, all the vaccines that we have
All the vaccines can be given.
Can be given in pregnant postpartum period.
Contraindicated in breast.
None of the vaccines is contraindicated, and they can be. So this is a list of all the vaccines that can be given in pregnancy. So challenges in vaccination.
Yellow fever, I think, should be avoided.
Yes, as far as possible, as far as possible. So we'll have just two challenges that we face during the vaccination schedule. Dr. Ashwani, can you just tell me which challenges you face while vaccinating a pregnant woman?
Madam, it depends. It's one is basically few are ignorant, and second is the cost factor if it comes to Tdap.
Yes, yes.
Those are the only two challenges.
Okay, Dr. Ritu?
Yeah. One is the economic burden. They are not aware of it. And of course, sometimes if there are such situations of high risk and needing immunoglobulin, something they may be very expensive for them.
Okay, Meena? Meena, any challenges at your hospital? Anything
Well, I mean, from our side, we would be recommending them. It is for them to take it or not. And definitely there are some patients who would not take this and take a simple TD or TT and not go for that. Influenza is one. Another, we started influenza in our antenatal regime, in fact, not all doctors were giving. So educating that and making it a part of our routine antenatal was one initial challenge, I could say, from our side, not the patient side.
Yeah, so
and also influenza, sometimes non-availability is also there. Maybe that vaccine change, the strain change, and it goes out of market.
Yeah. So the challenges and barriers can be many. Mothers may refuse vaccination, and when she refuses vaccination, then you have to just mention it on the antenatal card. She wished to avoid any potential exposure, public misconceptions about vaccine, and lack of knowledge about guidelines, fear, and litigation. And none of these are category A. So
basically, the more than the mother-in-law needs to be counseled, because they say that हमारे ज़माने में नहीं था. So then you have to tell them that these are the newer ones, and even the fact that in US and other countries it is given as a routine like tetanus, but and secondly that in India it is recommended by our organization FOXY for each and every patient.
So I could not find any data regarding the vaccination in pregnancy, but I could get the data of ACOG. You can clearly see that even only 55% of the pregnant women were vaccinated with Tdap, and flu vaccine was only 54%. So India, maybe we don't have the data of India, how many pregnant women are getting this thing vaccinated, but definitely
much less, I think.
Knowledge has to be there in the OBGYNs, and then the knowledge has to be put into practice also. So that is the main thing. Sometimes we know about it and we don't practice it. That is also a challenge, one of the challenge. So I'll just read out the COVID-19 vaccination in pregnancy, just 2-3 slides, and then we'll have the discussion at the last, and then we will close it. Now, this is a Government of India guideline that pregnant and lactating women have not been a part of any COVID-19 vaccine clinical trials. So therefore, women who are pregnant or not sure of the pregnancy and lactating should not receive COVID-19. Hence, we are not giving any COVID vaccine to any of the pregnant women. Now, ACOG has recently put in this statement in 2021 that ACOG recommends that COVID-19 vaccine should not be withheld from pregnant individuals. COVID-19 vaccine should be offered to lactating individuals similar to non-lactating individual. And similarly, FIGO has also put in a statement recently that FIGO considers that there are no risk, actual or theoretical, that would outweigh the potential benefits of vaccination for pregnant women. So we support offering COVID-19 vaccination to pregnant and breastfeeding women. And similarly, the FIGO has also put in this statement that we should counsel these patients regarding the level of activity of the virus, potential efficacy of the vaccine, lack of safety data, specific to its use in pregnancy, risk and potential severity of maternal disease, and timing of vaccination during pregnancy. Of course, when you vaccinate with the COVID vaccine in pregnancy, definitely any other vaccine should not be given for 2 weeks. So FIGO, ISHRE, ACOG, everybody is recommending the COVID-19 vaccination. So I would like to have the opinion on all of you. Should it be given in pregnancy or should it not be given in pregnancy? So starting from Raju, then Meena, then Dr. Ritu, and then Ashwani.
I think, as you rightly said, it should be the patient's choice. And if she wants to be vaccinated, one should not deny it to her. At the same time, you tell them that as per the guidelines given by the government, that adequate trials have not been done. So therefore, the safety is not yet sort of guaranteed. So therefore, it is not recommended. But yes, if you choose to take it for your own personal safety, you can go ahead.
Meena, what is your opinion? Should the pregnant women receive COVID?
It's what vaccine are we talking about? If it's Moderna or the mRNA, that is the Pfizer vaccine, then yes, they're recommending. But what we have in India is the Covaxin and Covishield, where the safety is not yet established. So we are talking about 2 different vaccines. And in fact, I think it was in Israel where I saw that the pregnancy and they're using the Pfizer vaccine. So they actually say that pregnancy is a high-risk situation and they recommend it as a priority basis, as in influenza. But for us, I think still we have that safety issues here.
Okay.
And as such, because...
Dr. Ritu, your comments.
Yeah. Because in India, we have the 2 strains and 2 vaccines, that is by AstraZeneca and the Bharat Biotech, inactivated. And of course, these vaccines have been found to be safe as far as animal-human studies are there. So I think we should leave it on the patient to decide. We can just put the pros and cons in front of her. But those patients who have really the pre-existing medical conditions, like diabetes or some others who have some sickle cell or something like this or dialysis, they should be offered because there the risks outweigh the
yes.
So they should be given.
Dr. Ashwani, your last comment.
Yeah. Madam, I think that like any other country, we are also struggling with whatever is coming up with COVID. It's a very, very evolving disease and the treatment is also evolving every day. New guidelines come up every day. So till we do not have any robust guidelines, we should leave it to the patient. It's completely their choice, but giving them the correct information is our duty. So we should definitely do that.
Okay. So thank you so much for that input. It was a wonderful panel, and I must summarize this panel that immunization during pregnancy should be considered a priority to prevent maternal, neonatal, and infant mortality and morbidity. Awareness and counseling in prenatal, intranatal, and postnatal plays a vital role. And vaccines do not save lives, and vaccination does. So thank you so much. And on behalf of the panelists, we would again like to thank Dr. Jaideep Tank for inviting us here and giving us this opportunity to have this discussion.
Congratulations, Preeti. As usual, fantastic moderation, wonderfully conceived and executed panel. And thank you very much to all the panelists for your excellent inputs. Ritu, Raju, Dr. Meena, Ashwini, thank you very much. I think it was an excellent panel full of information. And I'm sure that all the 4,824 people who are attending this session were quite happy with the way the panel went. Priyankur, if there are any questions, could you please take them down?
Yes, sir. It was a true reflection of what we actually had, because the number kept on increasing as the panel went on, which shows the sort of information that was disseminated. So thank you so much, Preeti ma'am, for that. And I just look into the questions quickly. And before I do that, no, sir, I don't see any much of questions anymore in the thing. There are a couple of questions that are about the COVID vaccine, but that I guess it's all.
Yeah, all lot has been discussed now.
Yes, all have been discussed. And there are a lot of.
There is one question, Priyankur, which says that, and it's from Dr. Shefali from Kanpur. And I think she's asking, if a patient comes in first trimester with dog bite, should we give the vaccine?
Yes.
Yes.
You can give.
Yes.
Because
and do you like to detect rubella IG before giving a RVAC by Dr. Shubhangi from Indore? Is the other question that I see here.
I think doing the rubella IG, it's an expensive test, so I think we can just forego and go for the vaccination.
Absolutely. And there are a lot of congratulatory messages that I see over here for Jaideep sir, Chandravati ma'am, as well as the panel. So thank you so much for being here today evening and spending such giving in such wonderful information to all our delegates that are present here. So I would, before we end the session, I would like to invite all of you to the next week's session on the 24th of March. We are having another wonderful session on Dr. Jaideep Tank's talk. Sir's talk will be on shoulder dystocia. Dr. Fessy Lewis sir will be talking on ectopic pregnancy. And we have a panel discussion which will be moderated by Dr. Archana Verma on electronic fetal heart monitoring. I would like to invite all of you for that session as well. And as I always say, we are there on all Wednesdays, 7 o'clock onwards. So I would request all of you to come and join the session. In case if you do not like the session, you can exit. But I'm sure the way the sessions are planned, you will not get an opportunity to exit. So please be there on every Wednesday at 7 o'clock with us. And thank you so much for joining today's session. And I would request Team Torrent to kindly now deliver the vote of thanks. And after that, we'll call it a day.
Thank you, Preeti.
Thank you, Jaideep.
thank you, everyone. Thank you, Priyankur, Dr. Jaideep.
Thank you, Priyankur. All the best for all your sessions.
Thank you so much.
Thank you.
Thank you.
Team Torrent.
No, I don't think there is anyone from Torrent. So I think we can thank everybody on their behalf.
Yes, sir.
And conclude the session. I'm happy to inform you that there were 4,824 people attending today.
Wow.
I'm sure that they have benefited from the deliberations. Everybody, thank you, Torrent, for supporting this initiative. And as Priyankur said, we'll be back next Wednesday. So thank you very much. Have a good night.